So I'd like to invite up our next speakers. So we've got Sam Khavandi and Ruth Watkinson. And they're going to be speaking on how can the NHS maximise its role as an anchor institution to boost local economies and reduce socioeconomic and health inequalities. So,
thank you. Click that. Let me just click that. Perfect. So thank you, everyone. So I will be talking about, as has just been mentioned, how the NHS can maximise its role as an anchor institution to boost local economies and reduce socioeconomic and health inequalities. And this is work that I've been doing alongside Dr. Ruth Watkinson and Dr. Luke Munford, neither of which could be here, unfortunately, so it's just me. However, alongside those two, there's also a whole wider range of people on this project, some of whom are actually here. And it's a lot of collaborations with lots of different arcs. I think 7 of the 15 arcs are involved. So there's a lot of arc power going on here. And I'm not going to name everyone individually, because there's a lot, but I'd like to acknowledge them nonetheless. So we'll start off by asking what is an anchor institution, and in particular in the context of the NHS. So by stating the obvious, we know that the NHS is a healthcare provider, but it's actually a lot more than this. It's a major employer. It's a major owner of buildings and land. It's also a major purchaser of equipment, services, food, and many other resources. And this all kind of creates jobs and opportunities that support the local communities. So if we think of it like we're at sea and there's an anchor on a ship and the anchor is thrown out to steady the ship, we can think of the NHS as an anchor which steadies the local economy and brings lots of benefits to the local communities as well. But the question is sometimes, is this the extent at which an NHS institute has or acts as an anchor in different areas the same between other places or not? And that's something some of our works hopefully should highlight. So why is it that the NHS can act as an anchor? Well, that comes down to, I think, its potential of the actual magnitude and size of it as an institution. And some fun facts here. We've got well, we know the NHS is one of the world's largest employers, as it employs about 1.5 million people, so that's a lot of staff. And in 2018-19, the NHS, or the government, spent 114 billion on the NHS. So there's a lot of money going in there, and that's money that's used to employ staff, to purchase equipment, to rent the land and the buildings and maintain them, which was all mentioned earlier. And all that money is essentially funneling into these local areas. And that kind of provides why the NHS can act as this anchor institute, as it can bring a lot of economic benefits towards those areas. And unfortunately, something I'm going to touch on a little bit later is that under current laws, providers and institutions in weaker economic areas are actually receiving less funding. So the aims and objectives of this project are the overarching research question: how can NHS organisations boost local economies and reduce socioeconomic and health inequalities? And we're doing this through 3 main objectives. And the first one is where we're involved in Manchester, and that's the analysis of the relationships between provider expenditures on staff and other anchor-related activities, as well, and how these impact social, health, and economic outcomes. And then the next step is to identify specific case studies and providers that we can look into, finding the underlying mechanisms of how these work, and finally creating that predictive model. So before we can think about where and why the staff expenditure and other expenditure impacts local areas, it's important to know where the money's coming from, how much is going to where. And this is something that was based on Matt Sutton's work in the past, a few years back, on how resources are allocated in England. So I'll give a little overview of that. So the Resource Allocation Working Party in 1976 actually gave structure the funding formula, and it's largely remained unchanged since then. And what the formula does is essentially targets shares to providers, so based on population shares. So there's adjustments made for demographic compositions as well as the needs. So that kind of creates this volume of service that is expected in an area. And then there's a further adjustment for area level variation. So that depends on the areas where there's high costs and whatnot. So at its simplest, we've got the equation there where target share is equal to the population share multiplied by age index, multiplied by the additional needs index, and those two are the ones that are making up that first adjustment for the population demographic, and then the final part, the additional cost index, and that's the area level variations. And each of these indices have a mean of 1, which is the national average. And what we've got here, well, it's not very clear on this board, well, this final bit is what we're kind of looking at today, and that's something that we're looking at, and that's called the market forces factors, the MFFs, and I'm going to come on to that now. So a brief, yet hopefully a comprehensive overview of what MFF or market forces factors are, using the who, what, when, where, why. So who are market forces factors for? They're for CCGs, hospitals, and GP practices. And what they do is essentially transfer substantial sums of money from CCGs or between CCGs and providers. And that's been continuously going on since 1977. And the where is where are the money, well, where is the sums of money transferred through? It's basically transferring across NHS budget from areas of low price and low cost to areas of high price and high price. And the why is the rationale being that areas of high price will require more money to provide the care that they do. And hopefully you're starting to begin to see the potential implications that this market forces factor can have on health inequalities as it's distributing the funds and shares of the NHS budget across the country differently. So here we've got a graph of the market forces factor by NHS regions, and we can see that throughout the regions it's very different. Over in the top right, we're seeing London, which receives about 20% share of that funding, up to 30%. And at the very lowest point, we've got South West, and I think that's due to Cornwall and Devon, so receiving lower amounts of funding. And then we've also got the North and the Midlands and East, who are also relatively low. And to put that into a more tangible perspective of it all, these are some figures we've got. So for an example, and every £100 that the Manchester University Foundation Trust receives, University College London Hospital Trusts receive £123. And then for Cornwall Partnership Trusts, they receive £95. So there are stark differences. And then to further put that into perspective, we found that, so in 2018-19, the University London College Hospitals received 890 million. So that's the best part of £1 billion. Without the MFF, so the market forces factor in that formula, they would have received 17% less. And that equates to about £148 million. And that 148 million is the same as the combined total of the 40 smallest trusts that received that year. So these are huge amounts of money. And then if we were to look at the distribution of money between CCGs, were we to remove the MFF, the market forces factors, completely? Now, of course, that's not something we're proposing or suggesting, but if we were to look at the differences, we would see that in the north, the CCGs would receive around £1.1 billion more, and most of that would be coming out of the areas of London. And were we to remove that MFF market forces factor, we would see that the South-West, the Midlands, and the East and the North would be the beneficiaries of actual such changes. So to bring everything together, we can see that, and we're aware that the NHS can act as an anchor in an institute, or anchor in a local area, providing a lot of benefits to those areas. And this is something that policymakers are actually promoting as a mission. And however, in contrast to this, we've got another national policy of how things are funded for, which is lying in contradiction to this, where we see areas of weaker economic activity receiving less funding. So I think what we see is a situation where there is a tension between two national policies, and that provides an opportunity and a gap that we can focus on to reduce these health inequalities, whilst also working towards contributing a levelling up agenda. So those are something that this project is looking to achieve out of it. Thank you.